Good afternoon. Welcome to From Belly to Baby. I'm here with Dr. Ebony Carter. She's a maternal fetal medicine specialist at Washington University and Barnes Jewish Hospital, and today we're at Missouri Baptist, so you wear all kinds of hats.
That's
or
right.
white coats, as the case may be.
Yes.
Tell us a little bit about yourself and your background and what your medical practice is.
Oh, great. So I joined the faculty here at WashU in September as a maternal fetal medicine specialist. Did my fellowship here, and prior to that I was in Boston for 3 years at Brigham and Women's, where I practiced general obstetrics, and decided I wanted to transfer to taking care of more high-risk patients. So that's what brought me to St. Louis.
So you've seen a lot of babies, a
Yes,
lot of moms.
That's right.
And know a lot of answers, which I'm really excited about. And just to give any of you who are joining for the first time a little background, my name is Abby. I work at St. Louis Children's Hospital. I am pregnant with my first child, 19 weeks right now, and going through this as a first-time parent, just like anybody else, the only major advantage I have, and I will say it is a pretty major advantage because I just thought of another question I need to ask you after we're done, is that I have access to all of these amazing clinicians, so I don't have to Google all of my questions. I just pick up the phone and call someone. So it's a little unfair for me to have that advantage and not share it. So
Which is a good thing for everyone to do. Come to us instead of Google.
I think we are, 4 episodes in? 4 for 4 on Dr. saying, please turn off the Google.
Google's a little scary.
And my husband tells me the same thing on a regular basis because when I'm home and I pull it out, it doesn't do much more than scare you.
Well, and people tend to share their scary stories. They don't share
Yes.
like the happy, wonderful moments, and so I think Google's a little bit biased in the view that you get.
And we talked about this a little bit last week too, and I find that also kind of among women in general, the things you remember, and I say this of memorable moments in general, you remember the highs, you remember the lows. And so if someone had a horribly negative experience associated with something, you say, oh my gosh, I have a pain in my side. Well, it's just, it's not hip flexor, what is it called? Round ligament, I guess. In most situations, but for that one person, it was something much more dramatic. And so you blow it out in your mind, and those chat boards do not help. So today, as we're talking about, things getting a little bit scary, we're talking about high-risk pregnancies, which you say high risk, and immediately I think all of us go, just brace a little bit. First of all, can you demystify this a little bit? What does high risk mean? Does it mean that you're an older mom? Does it mean that you come into pregnancy with a health risk to begin with? What does it cover?
So one of the things I love about my job is I have 2 patients. I have mom and baby, and either mom or baby can bring high risk to the table. So let's start with mom. Mom might have a condition that she brings into the pregnancy. Let's say she has diabetes or she has high blood pressure, and having those things in pregnancy means that potentially you're at higher risk of having some complications with the pregnancy. Sometimes it's not something you came into pregnancy with, but let's say that early on, heaven forbid, you're diagnosed with cancer or some really scary issue. That could make you high risk. And then on the other hand, the baby could make the pregnancy high risk. So let's say that we find out early on that there's some structural issue with the baby. Maybe there's a problem with the baby's heart or the baby's kidneys. Or maybe a little bit later on, the baby's not growing quite as well as we want the baby to grow. So those are some of the issues that can make the pregnancy overall high risk.
And next week we're going to be talking a lot about that 20-week ultrasound, that midpoint that I think a lot of us go into with the expectation that we'll just get a fun picture, but it's a whole lot more than that. And I know that at the Women and Infant Center on the main campus, Washington University, Barnes Jewish and St. Louis Children's Hospital, we tend to get a lot of patients, I understand, after that 20-week ultrasound. Backing up even farther though, does high risk encompass, first of all, let's talk about the age of mom. And I should say I'm asking these questions as oblivious as anybody else. So if you have questions, please don't hesitate to chime in and ask them as well. But what was it called? It was such a horrible term, a geriatric pregnancy, I think it was.
We call it advanced maternal age, or AMA. The technical definition of advanced maternal age is over the age of 35. We really don't start to get more concerned until a mom is 40. Over the age of 40, really the stillbirth risk is a bit higher, and that's one of the major concerns that we have. And as we get older, you tend to have more conditions like diabetes and hypertension. So 35 is kind of technically where the cutoff is and where we start to be more concerned about things like Down syndrome. And let's be clear, as a person who's over the age of 35, right? It's not like at 35 your risk of Down syndrome skyrockets. It's this continual thing that keeps kind of moving, And 35 tends to be the age at which your risk of Downs is similar to the risk associated with an amniocentesis, and that's kind of why it's the magical age where we start to worry and screen more for it. So yes, a number of things can make a person high risk. But backing up even more before the 20-week ultrasound and the first trimester, let's talk about how do we reduce the risk associated with pregnancy. And I think one of the most important things that all of us can do is a preconception visit. Now, granted, only 50% of the pregnancies in the United States are planned. And my definition is if you're not actively trying to prevent a pregnancy, you're planning one.
I think you're the second doctor to use that exact same phrase as well.
And in that
It's
situation,
true.
it's good to go into the obstetrician, and sometimes you know that you have some high-risk conditions, and sometimes you don't. And so I think it's a really good thing before you have a pregnancy to figure out, you know, what are the risks, what am I dealing with, and what are the things that I can try to prevent and take care of before I get pregnant.
That's so interesting when you say that. I do remember now, it was an appointment probably 6 months before I got married. I had said to my doctor something about, you know, we'll probably have kids in the next year or so. Little did I know it would be less so. But she said it changed the conversation entirely. There were a lot more questions. There were a lot more brochures that were handed to me just based on things that you can screen for in advance.
Right.
And it's incredible the amount of technology and information that is out there and that you can learn beforehand. Do you find that at any point I know we hear that information is power, do you find that there's too much information that we take in, or do most people self-select to the point that you get just enough to form a good picture?
I think that most people self-select to get a good picture. I definitely feel like in the age of the internet, it gets a little bit more scary and out there. But I think it's good for patients to do due diligence, and as physicians, we are here, right? So I would much rather a person come in and have a conversation with me than be terrified at home alone going to Google to try to answer these questions.
And every single woman, every single pregnancy is different, but are there any tips that you commonly tell people, and I think we've heard a lot of them in past shows, but anything that you would tell women to put yourself at optimal health before deciding, if you are in a position where you're deciding that you want to have children, that you can do to really make sure everything is in best order?
And I think a lot of that starts kind of at that preconception level. So one of the things is to get prenatal screens done. So there's certain vaccinations that are really good to have when you're pregnant that you can't get when you're pregnant because they're live vaccines. So all of that, like that's low-lying fruit. That's easy to take care of before you're pregnant. The other thing is a prenatal vitamin. So the reason we really care about prenatal vitamins in large part is because they have folic acid. Folic acid has been proven to reduce the risk of having a neural tube defect, so that the spinal cord doesn't completely close the way that we want it to, and you can have something like spina bifida, right? Very tragic for a kid, but if you take folic acid, that risk is significantly reduced. But guess what? All of that is happening before most people even know they're pregnant, so it's important to start taking that several months before you get pregnant. So those are the kind of issues that you can easily deal with. And then other things are optimizing medical conditions as much as possible. So diabetes, hypertension, obesity, trying to handle all of those. And then women who have autoimmune diseases. So let's say a person has lupus or ulcerative colitis. Autoimmune conditions tend to be much better handled in pregnancy if you have been symptom-free in the year preceding pregnancy. So I think a lot of us think, I don't want to take any medications, I don't want to do anything that could harm this little person who I love more than life. And we shoot ourselves in the foot by not taking our medications. So healthy mommy equals healthy baby, and certainly there are some medications that are absolute no-nos in pregnancy, but it's good to have that conversation initially and not just take yourself off of all of your medications, because if your disease gets out of control, then you haven't really done much to help yourself or the baby.
And it's so interesting that you bring that up, because we've had this conversation in our household about how, you know, I'm nervous, even though I have been told by so many clinicians, you can take Claritin, it's not going to hurt you. Allergy meds are fine. You do have that weird sense of, but what if? And I have to remind myself continuously the thing that I've seen at the hospital and that our clinicians have treated. We put women who are pregnant through chemo, who are diagnosed with cancer. So it is incredible the things that your body can do and can manage outside of, and still take care of a baby.
Right, and it's all about kind of managing risk and benefits. So if a mom has cancer, that's life-threatening, and so you're willing to take a higher risk with chemotherapy in that situation, because if mom doesn't survive that baby is not going to survive. And then there are people who have called me and, you know, kind of want to take all of these medications and the underlying condition isn't so serious, and it's like probably not worth the risk in that situation. But that's what we're here for, is to help people balance those risks and benefits and make the best possible decision for the growing family.
And do you work not only the hospitals here in St. Louis, but you work with outside hospitals as well. So we have a lot of, obviously not all women are able to be in a place where there are these huge medical centers. I mean, I grew up in a teeny tiny town and we have a great community hospital, but it still doesn't have the resources available. So are you able to communicate with those outside hospitals in
Yes.
order to maximize care for a mom?
Definitely. So we travel, we have several sites in the St. Louis area. We also travel to several sites in southern Illinois, and we have telemedicine so that people who can't physically get here, we actually have a nice little room at Children's, and so we can talk to each other on the screen and communicate.
Not all that different from this, which is amazing that you're able to do that, but it really just helps to have that conversation going. And if mom needs to be transported at some point to a major facility, you guys are able to work that out.
Well, all of our patients who come here who live far away, we give them a little pin that has our transport number and say, we will come get you, whether it's by ambulance, helicopter, plane, you know, give this to the provider where you are and we will come wherever you are and pick you up, essentially. So it's a great service. I think we should probably talk a little bit, if there's no questions at this point, like how do we manage patients in a high-risk setting? And I think there's several models. So let's say that you're 12 weeks, there's some condition that's making your pregnancy high risk that your obstetrician doesn't feel totally comfortable with, and they say, go see maternal fetal medicine, which is what I do. It doesn't necessarily mean that you have to leave your home physician who you're bonded to and you want to be with. So there are a number of models. One is that you come one time and we talk about what's going on and we make a list of recommendations and communicate that back home to your doctor, and hopefully you'd never have to see us again, right? And that's the end of it. But if something arises and things get a little bit more complicated, the relationship is there, it's established, and we're always available to you. There's also a hybrid model where the doctor at home says, you know what, this is a higher level of care than I can provide. I can do her basic obstetric care, but you manage her sickle cell or whatever else is going on. And so patients are seen at home and they come see us every 4 weeks or so, and we work together with the doctor to manage it. And then sometimes things are so complex, just come on over and we do everything and manage care here and deliver the patient here.
Okay, so I thought this is so funny when you mentioned sometimes it's a one-time only visit. I was in a meeting with one of your colleagues, Dr. Bebbington, who is a fetal surgeon, and he was talking about his, I think people forget that oftentimes we give great news. And so that he said there are times when you are referred to us and we're able to look at something and say, oh, this is something we can totally handle, or this isn't, this is something we need to watch, but you don't need to worry. So I do want to throw that out there as well, that I previously always associated maternal fetal as being, that's the last place in the world you want to go, but at the same, no offense, but at the same time, there is real opportunity there to just understand what the situation is a little bit better.
I had that situation earlier today. I saw a patient whose last baby had lots of issues, lots of complications, and understandably she's terrified with this pregnancy, and saw her doctor yesterday, and they said the same things to her that she remembers hearing when things went poorly in that last pregnancy. And so she came and was in tears and so upset. And it was wonderful to be able to do the ultrasound here, to do a high-level ultrasound, look at this baby, and give her that reassurance that, nothing in medicine is ever 100%. But to the extent that I could say, the things that happened last time, those things are not happening, right? All signs point to the fact that this baby is doing really well. So I don't get to do that all the time, but it was nice to kind of just give that sense of relief for someone who's been traumatized by her last pregnancy.
And I think that brings up a really good point, and a question that I had earlier is, if you have one high-risk pregnancy, does it automatically mean that your next one is going to be high risk, or that it's going to be treated as high risk?
It does not. So it depends on what the issue was in the preceding pregnancy. So let's say that the baby had issues with growth, right? So certainly you're at higher risk for the next baby to have growth, because what was the underlying issue that caused the growth problem in the first place? But not necessarily. And that's really just a call to us to say, pay close attention, right? Like, follow it closely. But it doesn't mean that you're going to have that same issue again. Versus a mom who has a chronic, lifelong condition, then yeah, that's probably going to be an issue with every pregnancy you have. So it's really a on a case-by-case basis.
Okay. And of course, I mean, it always starts with that visit to your primary OBGYN, and they will then refer out as needed, or do you ever have patients who start with you?
Yes, we have some patients who just self-refer and they're like, here, I'm yours, right? So we see, usually the patients come from their primary obstetrician, but we see both.
Okay. And talking about the baby itself, are we at a point where we can discuss the 20-week ultrasound and what you learned from that, do you think?
Sure.
In the conversation? Okay.
Mm-hmm.
So that is such a big,
we can talk about the 20-week ultrasound. Do you want to talk about the genetic testing before that? Or?
Sure. We've talked a little bit about it in the past, but I'd love your take, because that is something that I think a lot of women really struggle with it, myself included. I had a really hard time deciding what to do and what not to do, just because I've said this before on this program, I'm 34 years old, so I'm not quite to that 35 mark where everything is insurance is going to cover it regardless, so may as well go ahead with it. And at the same time, there's that, do I really want to know? I mean, what it does, if I know, do I automatically have to make a certain decision?
I think the best way to think about any testing, including genetic testing, is what would I do with this information? How would I handle it, and how would it change my behavior? So we offer every single mom genetic counseling, genetic testing in the first trimester. And I use Down syndrome because most of us know what that is, but there's other things that we can test for as well. And usually that testing happens somewhere around 11 to 13 weeks of pregnancy. And we offer different things based on what the risk in the mom is, right? So some people will be offered a first look, and that consists of an ultrasound. Babies with Downs tend to have a thickened fold behind their neck. And then there's also blood work that goes along with it, because there's certain chemicals that are higher or lower in the blood of a mom carrying a baby with Downs. And you put that together and you give mom the risk. So we might come back and say to you, the baby's risk of Downs is 1 in 10,000. Great. That's pretty low. Nothing else to do. What if we came back and said the risk is 1 in 3? Well, that's a lot more concerning. We probably should do a little bit more testing. And so how do you know if you wanted that in the first place? And I think there's 3 groups of parents. Group 1 would say, if the baby had a really severe issue, I would think about having an abortion, and that group should get the test. And group 2 would say, I wouldn't have an abortion, but I would want to know so I could emotionally prepare to take care of a child that was going to have some special needs, and that group should definitely get the test. And group 3 would say, I wouldn't have an abortion, I don't need to emotionally prepare. Even if I got the test and it was positive, I would say, I don't want an amniocentesis, thanks but no thanks, where we stick a needle into the belly and take some fluid from the baby to send it off for more definitive testing. So if you don't need to know to emotionally prepare, and you're not going to get an amniocentesis anyway, don't get the test. There's no reason to do it. I remember having a patient back when I was a generalist who had a risk of Downs that was 1 in 74, and she was terrified. And I kept saying, but the chances are 73 and 74 that the baby's just fine. And that was of no comfort. But she didn't want an amniocentesis. So she spent her entire pregnancy terrified there was something wrong with her child. And so in that situation, all we did was provoke her anxiety, right? So if you're not going to do anything with the information, say thanks but no thanks for the testing.
That is really very succinct advice. And I think we have a question.
We have a lot of questions coming in all of a sudden. So Trina is saying that she's 36 years old and she had a gastric sleeve. So with those 2 factors, would she qualify as high risk right out of the gate as she became pregnant?
Yes. So I think that it's certainly worthwhile, first of all, get a preconception consultation, number 1. And then number 2, I think it's worthwhile to have a consultation with a maternal fetal medicine physician. If everything is well controlled, it's possible that you can go right back to your obstetrician. But we like to check a number of labs to make sure there's no nutritional deficiencies. Another thing to be concerned about if there's any type of gastric bypass surgery is screening for diabetes is important in pregnancy. So I always say pregnancy is life's ultimate stress test, right? It puts your body through a lot, and it exposes some of the things that you're more likely to have happen down the road, like diabetes. And so certainly anyone who had gastric bypass is going to be at higher risk of having diabetes of pregnancy. But the test that we use doesn't work so well for people with gastric bypass. It's this disgusting little sugar drink that people often can't handle, and complications can arise from that. So there's some other little special things that we do in pregnancy for a woman with that history. And so I think a minimum of a one-time consultation with maternal fetal medicine is warranted, preferably before pregnancy.
Okay.
Ashley says that in her first pregnancy she had a placental abruption. Is she automatically high risk in the second?
So I would say you're mostly at risk for having another abruption. And the question is, what was the underlying thing that caused that abruption? So let's back up for all of the other viewers and say, what is an abruption in the first place? And I think most of us know the afterbirth, right? Normally you have the baby, and then the afterbirth, which is the placenta, and that helps the baby get nourishment, comes afterwards. So if my hand was the uterus, and this is the placenta attached to it, and then I'm the baby, right? The issue with an abruption is that the placenta starts to separate prematurely while the baby is still inside, and you can have bleeding in that area that sometimes stays in the uterus, so you don't even see it, and sometimes mom starts bleeding. And when about 50% of that placenta has separated, babies can get stressed out, and it can be a horrible emergency. I mean, even as bad as like resulting in like the baby dying.
May I ask how you know?
So usually it's a clinical diagnosis, and so blood is an irritant to the uterus. So when that starts to happen, a lot of times people start booming out contractions really quickly. It's like very uncomfortable, painful. Sometimes if it's not concealed and the blood is coming out, you're having vaginal bleeding. And the things that can kind of precipitate that are, I think probably the number one thing is a really high blood pressure. So women who have preeclampsia and high blood pressure are at higher risk of having that happen. So sorry, I went all the way around to now get back to the question. There's certainly an increased risk of abruption happening again. If that abruption happened because of preeclampsia or because of blood pressure issues, those are certainly things that we can try to address. So things like baby aspirin have been shown to reduce the risk of preeclampsia for moms. If blood pressure was an issue, we can try with other medications to control the blood pressure. So I'm speaking in very broad terms, like of course it's individualized to each patient. But the answer is yes, there's a risk of abruption happening again, but I think learning from the lessons from the last pregnancy and optimizing health as much as possible means that the chances of having a pregnancy without an abruption potentially are a lot better once you've optimized health.
And just to interject, I know there's going to be so many specific questions, especially given the topic that we're addressing today. We are able to answer, Dr. Carter is able to answer in very general terms, but always, 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 and we talked about this before, every woman, every pregnancy is different. So talk to your own doctor.
And I know I sound like a broken record. I would say go see your obstetrician before getting pregnant again to talk about what were the specific circumstances surrounding that abruption and how do we try to minimize the risk of that again.
Okay, disclaimer issued, more questions, go ahead.
So Melissa has a question. She is a triple transplant patient.
Hot dog.
Yes, and she's thinking about getting pregnant. Is she automatically high risk? And have you ever worked with a woman who has had a transplant in the past?
Yes, we actually have several patients in our practice now who have had transplants. But that's a situation where I'd say certainly before even thinking about pregnancy, would want to see a maternal fetal medicine physician. And then I should say now that part of the reason why I love working at WashU and love working with Barnes is we don't work in a silo, right? This is definitely an interdisciplinary effort where the obstetrician should be speaking, very closely with like the transplant physicians, the medicine physicians to really make a good plan. Because sometimes people come to us pre-pregnancy and we're like, you're great, go for it, get pregnant. And sometimes we say, you know what? I'm worried about how some of these other organs are functioning. We've gone through a lot, and the risk potentially outweigh the benefits, and maybe we should think about other things than pregnancy, like a surrogate or some other options. So, it's very different. It's on a case-by-case basis. Sometimes transplant patients are good to go and we're ready, and then sometimes we say, I'm really, really worried about, your health status. So it kind of depends.
Okay. And Tracy has a question. She says, if you've had a pulmonary embolism, does that automatically make you high risk?
Yes.
That was a very straightforward answer. Can you
So,
explain what a pulmonary embolism is?
Pulmonary embolism is a clot that often starts in the leg and then can dislodge and travel to the lungs, and it's potentially life-threatening when it happens. And there are lots of things that can make a woman higher risk for it. So sometimes it's like something genetic and you're born with just being at higher risk for clots happening. Sometimes it's provoked. So let's say that you were in a bad car accident and you were in a cast and you were in bed for a long time and you're, kind of lack of mobility. Or let's say you took a plane to Taiwan and you were sitting in that plane seat right? So there's different things that can cause it. And so for any woman who's had a clot, we want to look, first of all, what's the underlying reason that you had the clot. And in pregnancy is also a risk factor for having a clot, right? So it's a higher risk condition. But thank God there's really nice medications that reduce the risk of having clots that we can use in pregnancy. So once again, it's one of those kind of a case-by-case basis in terms of would you need to be on anticoagulation during the pregnancy. We can do 2 different doses. One is trying to prevent it, and it's a lower dose. And then we can do a higher dose that's saying you're at really high risk, right? We need to do a little bit more in this situation. And that high risk associated with pregnancy for clotting isn't just when you're pregnant. It actually extends to 6 to 12 weeks after you have the baby. So it actually continues after childbirth.
It is so fascinating, and I think we'll explore more of that as this whole series unfolds, but how much of pregnancy does continue beyond delivery. It doesn't stop as soon as baby's out by any stretch. I mean, we've heard from many people that 6 to 12 weeks later, you're still seeing your doctor and still seeing a lot of the issues that are associated or could be associated with pregnancy.
Right.
So are we good with questions right now? If you have any more, please keep texting, or pardon me, messaging us in the, or typing them into the comment section. And if we miss them, it's not that we're ignoring you. Sometimes they just keep flying in quickly and we don't see them, so ask it again, don't hesitate. So I think that brings us, or at least we were at some point talking about that 20-week ultrasound. And I am so amazed at how long they take, because I think everybody, or at least obliviously, you kind of go into them and think, I'm just going in and this is my first shot to take a look at my baby.
Right.
But that's not all you're doing. You're taking a darn good look at that baby. What all are you looking for and at?
So I think the patient thinks we're looking at gender, which we do. We definitely do that, but that is like 1% of that anatomy scan. So I'm going to go from head to toe. We're looking at the baby's brain and making sure that all of the anatomy looks normal in the brain. We're taking a really good look at the heart and making sure that all the connections that are there are the way that they're supposed to be, and the belly and the kidneys, and then all of the limb measurements and making sure that they're right. So there are different levels of ultrasound. So I'd say a woman who is coming into the pregnancy high risk because of a genetic condition, or let's say mom had a heart problem herself, you want to try to get that ultrasound at a center that is used to seeing anomalies or structural issues in the baby, right? A very high volume center that's doing lots of them, because all ultrasounds are not created equal. So yeah, we're looking at a lot of anatomy, and I say the average anatomy scan probably takes more in the order of 45 minutes. So yeah.
Okay. And once you've had that scan, what information are you able to take away from there? Because that really, I mean, aside from the testing that you're able to do prior to that, that really gives you an indication of any additional care that baby might need. So what do you see sometimes that would indicate this mom needs to go for more testing or whatever?
So sometimes we see that there's an issue with one of the organ systems. So let's say that on the heart views, I'm just not completely satisfied that I've seen everything that I wanted to see. We might refer that mom on to a fetal echocardiogram, which is, you know, an ultrasound of the heart on the baby's heart. And we do that at Children's, and we have a phenomenal team there. And that's kind of all, you know, like sonographers who just really focus on that, and they can get a better view than even we can in high-risk obstetrics. So really the anatomy scan is kind of a flag to say, you know, either everything looked great and we can go on and this is a routine pregnancy, or we need to look at this a little bit more carefully. The other nice thing about an anatomy scan is we can hook moms into the care that they might need for their baby. So let's say that there is a heart issue and that baby is going to need surgeries and other issues. We have a fetal care center here and a dedicated fetal care nurse who really is the guardian angel for those patients, right?
She's amazing. I have seen her with one patient after another, and I totally have to interrupt you and sing Sarah's praises, because I saw her with a family the other day, and outcomes aren't always perfect and exactly what you want. And we've seen a couple of situations, and going back to the genetic testing and deciding what you're going to do, I've seen her with the families of children with, and I know I've asked this question in I think every episode, the trisomies that are not Down syndrome. There are
13
two others.
and 18.
13 and 18 that are almost, are they always or almost always fatal?
Almost always.
Almost always fatal. And there are a number of families who make that discovery and then determine that what they want to do is plan what time they will have with their baby. And she helps facilitate a great deal of that. Make sure that mom and dad are able to bathe baby, or that
you have pictures.
That you have pictures and the prints and everything, which is so incredible. So I think that that's something that when you talk about the Fetal Care Center that a lot of people aren't necessarily aware of, is that it's there to help get baby healthy, but also to help empower a family's decisions and make sure that regardless of how you want to spend that time with that baby, that those wishes are honored.
Right.
So,
and the fact that there's going to be several pediatricians involved in this baby's care, and so wouldn't it be great to know your baby's dream team before that baby's here? And so that's part of the Fetal Care Center, is making sure that all of those connections are made so that when this little one arrives, we have a great plan in place and a great set of people to take care of this little one.
And I know I'm a grown adult, but there is one of the fetal care physicians. I have asked her to adopt me a few times. I would be a very old child for her, but we'll actually meet her in a couple of weeks when we talk about the fetal echo and those kinds of things, that the additional testing that comes after baby is born. But I'm sorry, I completely interrupted you. But so there are things that you can go on to the Fetal Care Center for, and then what else do you learn from that ultrasound about baby?
So we get a first chance to see the baby's growth. So let's say that a person didn't want any genetic testing in the first trimester, right? And then you see a few things that suggest that we're at higher risk of maybe having a chromosomal disorder. You can revisit that then and say, look, there's some things that make us a little bit concerned about this. Do you want to get an amniocentesis? Are we interested in looking into this further? Or if there's already some growth issues that early on, then it might trigger more testing in terms of, could there be an infectious reason why this baby is small? Could there be a genetic reason? So I feel like part of obstetric care really is minimizing risk. We've talked about risk a whole lot, and the anatomy scan is a nice time to be able to pick up things and then make sure that we're trying to optimize outcomes for the rest of the pregnancy.
And it really is remarkable, and we'll see the pictures next week, how much you can tell from a tiny little black and white image. And just the amount of detail that you're able to gather is pretty phenomenal.
Well, and I have to sing our sonographers' praises. So the sonographers are the people who actually do the ultrasound, and they are a highly skilled, competent group of individuals who catch nearly everything. So we're really, really lucky to have that team here.
And for the vast majority of women, I think it's important to note that 20-week ultrasound, I went in kind of nervous. I'm very, very scared, which is so funny because a lot of my friends were like, why are you scared? It's so exciting. And it is exciting, but I think whenever you see all of the what ifs, you get a little bit more nervous. But the vast majority, you send out the door without a single one.
When I was a general obstetrician, I used to say my favorite part of prenatal care is the anatomy scan, where you get to see 10 little fingers and 10 little toes. And if you don't take anyone to any other part of your prenatal care, take someone with you to the anatomy scan, because usually it's a time of great joy and getting to see your baby. And every now and then it's not, and it's good to have someone who loves you and cares about you and can be another set of ears to hear what's happening, be there with you.
I think that is actually a point we didn't talk about addressing, but it's really important, and we don't want to take for granted in any situation. We see women who come to us in a number of different capacities coming into parenthood, some who have a partner, some who do not. What is your advice whenever you're talking about going through a pregnancy? I mean, it's 9 months, it can be hard. How do you build a support team if you don't have one that's just automatically in place? Do you give your patients advice on that ever?
Well, actually, I do group prenatal care for our patients with diabetes, where we have groups of about 6 women who all have type 2 diabetes or diabetes of pregnancy, and they get their care together. And one of the activities that we do in our groups is a support map, right? And at the middle of the map, it's a little circle, and it's mommy and baby. And right, because usually it's just going to be you. And then the next circle is who can be instantly available to you, right? And sometimes people will say the father of the baby, or a parent or grandparent or whatever. And then the next level out is who's going to be available to you, like not instantly, but within a couple of hours they could get there. And we have some patients who feel like they have absolutely no one, right? But by the time we go through that map, and then the next one is like, who can you call and they can be with you within a day? And that's us, right? Like we fit in that category, just to help people realize that there are lots of resources that are around for our fetal care patients. Sarah is going to be in one of those inner circles of the map, but we really are here to support mom through the pregnancy and after the baby arrives.
it's talking about Sarah. I saw her the other day with a family that had lost a child, and they were doing some things at the hospital several months after they had lost him to honor his memory, and she was having a really hard time coming back into the hospital, which naturally you would. And she just took this woman by the head and kissed her on the forehead, and I thought that it was such a thing that a mom would do that I had to step away, because I thought it's so amazing that she was very clearly a connected part of her care team. And I've seen her hold hands of women, and there was one delivery where Dad was in the room, but he was very distracted, and so Sarah was there holding Mom's hand as during the C-section, which was amazing. And Mom was perfectly happy. I mean, she was nervous, but she was very happy to have both sources of support there. So.
Right. And another thing to think about, if it's possible, is a doula. So, if you want to have your childbirth experience and don't have a person who can be with you, doulas are also wonderful support people and resources to have available.
Can you have a doula in a hospital? Yes. I think that's something I know that I didn't know beforehand. I thought that was something that was reserved only for birth centers or something, but that's a decision that you will support within
Doulas
a hospital
are
system?
more than welcome.
Okay, fantastic. All right, I saw a finger up, we got a question.
So Morella asks if you would recommend pregnancy to someone who has had systemic scleroderma but does not yet have organ involvement. Very specific question.
Very specific, and I would say come see us for a consultation or some maternal fetal medicine physician somewhere for a consultation beforehand. Because I think at that point, really all of the records need to be reviewed from the outside place. And let me put a plug in for that too. So when you go for a consultation for any physician and come with no records, it's a waste of time. The person's going to say, get the records and come back and see me then, because you're basing your recommendations on nothing. So I think it's always good to have all of your records. If you can have them with you, in addition to sending them ahead of time, that's great, so that we're really not wasting your time and giving you the best possible recommendation. Because for that patient, I would want to pour through all of those old medical records and kind of see exactly what we were dealing with.
And on the patient side, what would that look like? Would they go to their current doctor's office and ask for everything to be copied? Would they just have it be sent to your office?
So usually you have to sign a release of information form saying I give permission for my medical records to be released, and then the physician's office will send it to us. I can't tell you how many times things get lost in translation. I actually think it's much more efficient to go get them physically yourself, send them yourself, and then have your own copy. So when you get there and they're like, oh, I didn't see it in the computer system, it's like, here.
I've had this happen before, and I can tell you, if you have a hard copy in your hands, it's awfully reassuring, because you can walk. I mean, computers are great until they're really annoying. All right, do we have any other questions right now? All right, so the other thing we talk about are sometimes, most of the time, before the 20-week ultrasound, but I've known a few people who have gone into the 20-week thinking they were pregnant with one child, coming out with more than one. So if you have multiples, does that automatically make a pregnancy high risk?
Yes and no. So if you have twins, specifically die twins, where each twin has their own placenta, that really can be managed by a general obstetrician in most situations. If you have twins that are sharing the placenta, or they're sharing the amniotic sac that they're in, that's a higher risk pregnancy and should really be followed by a maternal fetal medicine physician. And for twins in general, you have to pay closer attention to growth and those kinds of things. So I guess the answer is depends.
Okay, gotcha. And then let's see here. You know what? It happens occasionally, but I totally lost my train of thought. I totally had a subsequent question to that. But and then are multiple pregnancies followed more carefully or more routinely? Do you see patients more often? We
tend to do more ultrasounds and more non-stress tests. So one of the things that we think about with high-risk obstetrics, especially, the way that we handle an issue that arises at 24 weeks is totally different than the way we handle exactly the same issue at 37 weeks. And why is that? The question I'm always asking as a physician is, where is this baby doing best? Is it doing better inside mommy, or is it going to do better in our intensive care unit or out in the hospital? And at 24 weeks, the answer is almost always keep that baby inside mom. And the closer you get to 37 weeks, which we consider full term, the less foolishness you're willing to put up with from a fetus, right? Like the threshold is much, lower to say, no, we need to deliver at this point. So, and now I lost my train of thought in terms of, like, I went on a tirade. What was
No,
your
that
initial
totally
question?
makes sense if you see a doctor more often. And
Yeah.
so you said at 37 weeks.
So, you know, if we're worried about the risk of stillbirth or a really concerning outcome like that, there are tests that we can do that reassure us that, hey, baby's okay. So let's talk about ways that we reassure ourselves that a pregnancy is going well. From the mom standpoint, movement is really important. So moms will say, oh, this kid moves so much, I'm sick of it. And I'm like, there's no such thing as too much movement. We love movement. Movement is a kid's way of saying, hey, mom, I'm doing okay in here. It's when a kid's not moving that you have to be worried about it. So, you know, you should talk to the general obstetrician about kick counts and other things to reassure yourselves in terms of how the baby is moving. The next thing we can do are non-stress tests, and that's where you kind of sit in a lazy boy, and there's 2 monitors on the belly. One is looking at contractions, the other one's looking at the baby's heart rate. And a happy, healthy baby, their heart rate looks like a sawtooth pattern. It kind of does this thing, and every now and then it has an acceleration and looks great. And so when a kid does that, it's saying, I'm doing okay in here. Things are looking good. So that's another reassuring factor. And then the last main thing we use is something called a biophysical profile. So that's an ultrasound where we look at the baby, and there's different domains of a kid, you know, moving and kind of flexing, practicing the breathing movements inside, looking at how the fluid looks. And if the baby gets all of the points on that, that makes us feel great. So any mom that we're worried that her risk of stillbirth is higher than other moms, we will do that testing, and we start to do it more later on, right? Because at 24 weeks, even if it's not looking great, I don't want to deliver you. At 37 weeks, oh, we're going to deliver if something is not looking great. So we have all kinds of tools in our toolbox to reassure ourselves that this pregnancy is going well, it is safe to stay inside.
And do you tell moms ever to trust or not trust their instinct when it comes to how much they're feeling the baby move or anything like that? Is there ever any harm, I should say, in calling the doctor and saying, I'm a little nervous about this, that, or the other?
I would always rather a mom err on the side of calling us because we talk about kid counts. So, you know, babies have sleep and wake cycles just like we do. So some moms will say, like, oh, my baby is up all night, but I don't really feel him too much during the day. And so pay attention to what those patterns are. And when the baby is breaking the pattern and not moving and you're scared, you do kid counts, right? Like drink some juice. So, you know, the sugar kinds of wakes the baby up, and then start counting. And, you know, there's different parameters for what people say, but generally within an hour you should feel 10 movements from a baby if you sit and do your kid counts and pay attention. Now, like right now, probably not paying attention, right? We're talking, doing other things, so really you want to like sit down and focus on nothing but that. And if your baby doesn't get the kid counts, and I'm talking more like 28 weeks now, like littler babies don't do this as well, that's when you call the doctor. Like, movement's important.
And it's interesting, and I feel like Jenny's totally the man behind the curtain here. Do you mind if I ask you a question related to your experience? Because that happened to you, right? That it was lack of movement. Can you talk a little bit about it?
Yeah, so it was 26 weeks and 6 days, and he stopped moving. And so I called. It was like 4 p.m. in the afternoon. They got me in for a 9 a.m. appointment, and it was an umbilical cord accident. And they said had we waited 1 day to call, he would have died. So...
And we should know you delivered at how old?
Exactly 27 weeks, and he was 2 pounds.
And he is 7 years old
and sassy and healthy
and cute as can be.
Perfect.
Yeah.
Yes.
So, lots of time in the NICU.
Happy ending.
Yes, very happy ending.
But obviously worth calling on that gut instinct.
And you know, to the gut instinct, I will say, people say, I don't want to go into the hospital and they tell me it was nothing, or I don't want to go in and think I'm in labor and they tell me it's nothing.
My big thing is I don't want to be a bother. I don't want to, and I know there are people with bigger problems. I'm like,
be a bother, right? Yeah. So I would always rather have a patient who comes in and gets evaluated and we're like, everything looks great, and you get sent home, than to be at home terrified that something is wrong. Because when people come in with stillbirths, I can't tell you how many times the story is, you know, I hadn't felt the baby move in 3 days. Right? And when I hear that, before I even put the ultrasound on, I am terrified that that's a stillbirth. So I think part of it is, as obstetricians, we need to do good education, teaching people about kid counts and to be aware of movement. And then for patients, it's always err on the side of calling, and it's better to get that reassurance than to be scared alone.
And don't let Google tell you that it's okay. My husband Googled that afternoon, and he said, well, I read online, and it said around 27 weeks the baby grows really fast, so there's not as much room, and so you won't feel it as much. And so I almost didn't call because of Google. Yeah. So
well, listen to the doctor, not
Always.
to the Google.
Always.
I feel like that could be the name.
We are like hammering that home.
Yes, Google is so going to come after us. But is there a point at which you would start following a patient between, let's say, 21 weeks? So you've gotten past that 20-week ultrasound, everything looks fine. And I picked 21 totally out of the sky. But that and then delivery, is there a point at which maternal fetal medicine would come into the picture, or usually have you identified by that point patients that are going to be more high risk?
So in a low risk patient, normally they're seen every 4 weeks by their primary doctor, and then the closer you get to term, it becomes every 3 weeks, every 2 weeks, and finally at 37 weeks, it's every week.
Mm-hmm.
For patients who are seeing us, there's usually something else that's going on that means that we're going to follow them more closely. And so for many of our high-risk patients, we will do another growth scan, right? Because growth is another indication of a kid saying, I'm doing pretty well. And when a kid starts to get stressed out, we go down this predictable path of events, and one of the early events on that path that goes not so great is growth. So we pay a lot of attention to it. So, we might do a growth scan between 24 and 28 weeks just to kind of see where we are. And if the growth isn't great, then that's when we start to do some of these other tests that I already talked about, like the non-stress test and the biophysical profile. But it's totally different for every patient, and it's kind of a case-by-case basis. We have some general guidelines, like we do certain things for diabetes and certain things for hypertension, but a lot of it's individualized.
Okay. And this is going back to a point you were discussing previously about whenever you look at baby and determine whether they would do better in mom or outside. Mm-hmm. And I want to point out that I've only seen this a time or two. You can speak far more intelligently toward it. But when you're talking about combining that with multiple pregnancies, the answer is sometimes different for each child. So how does it then become a team effort to decide at what point you are minimizing risk to both babies?
So it can get very difficult and ethically complex when you're dealing with multiple pregnancies because you're worried about mom's health, right? So you have, certain conditions like preeclampsia, which is characterized by high blood pressure in mom. A lot of times moms will have protein in the urine, and the risk to mom is seizure and stroke, and the risk to baby is not growing well and kind of going down that whole path, trying to prevent stillbirth. In that situation, so let's say that a mom is diagnosed with preeclampsia at 26 weeks. What is in mom's best interest? Delivery. That's the cure. She should be done with this pregnancy. But a 26-weeker is super sick, mm-hmm. and we would rather not meet this little one at 26 weeks. And so if we can keep mom well enough, we're going to try to push the envelope a little bit further to get the baby time, realizing that this is not in her best interest, right? Mm-hmm. So I feel like we are often balancing the risk for mom and baby. And then when you have twins or triplets or quads, right, it becomes even more difficult. So we had a situation recently where we had a lady who had, several babies inside, and one of them had a heart defect and wasn't growing so well. And what do? Do you deliver all of the babies because the little one has this heart defect and is not growing and isn't doing well? Or do you risk having that baby potentially pass away to try to get the other babies as much time as possible? Those are heart-wrenching decisions, and when it's a clear, evidence-based, black-white decision, I say to the patient, this is my recommendation, and this is why. In that situation, I couldn't really tell them this is what you should do because it's a really personal decision. All I can do is kind of give all of the information possible so that family can make the best possible decision for them.
And these are days when I am grateful that there are other people to look at those situations because I cannot fathom having to be the person who says, and I know you've got so much education behind the decisions that you make, but that is, when you get into those gray areas, it just becomes really tenuous and I think unnerving.
And there are lots of them because when I did my residency, which is now 10 years ago, 24 weeks was kind of the period when a baby could live independent of mom. And we stuck firm and fast to that 24 weeks. And now with medical advances, it's creeping back. So now maybe it's 23 weeks, and maybe for some babies it's 22 weeks and change. And how do you make the decision about what to do when you're in that period where maybe the baby can survive? It's
and what
hard.
The consequences are too, and we'll talk a little bit, and I believe it's in probably 6-7 weeks. We're going to be in our newborn ICU talking to some of the neonatologists about what they see, and it's going to be at about that 26-27 week mark. But yes, you can. Technology is incredible, and we can save these babies very early now, and we can give people a lot of resources, but it is still, there are so many decisions that come with that about the consequences that you're going to live with down the road.
And I think that's what we have trouble counseling patients with on the labor floor, right? Because you hear, do you want everything done for your baby? Yes, of course, right? Like, that's a no-brainer, but what does that mean? So you have a baby that's living on the edge of viability and is not going to live for very long potentially, and how do you spend that time? Do you spend that time rocking that child so that in the time that they have, they feel love and warmth? Or do you spend that time doing chest compressions and putting breathing tubes down, and right? And it's really hard, and I don't have an answer for it, but I think I'm looking forward to that session in 6 weeks so that some of our neonatal intensive care unit colleagues can share that, because I think that's the part that's really hard for parents to understand when they're at those early gestational ages.
Do you ever counsel people to make many of these decisions before they get to that point, that you're going to have a baby early? Here are the things you should consider, or really is it, and I don't know if it, and I hope never to know, but do you make those decisions in advance, have your baby, look at your baby and say, I know I said X, Y, and Z, but I want you to pull every plug you've got and fix this?
So the vast majority of the time we don't have that luxury. It's kind of happening in real time, and you're making the best decision you can. For some families that know that their child is going to be born with a condition that's not compatible with life or life for very long, then we also have a palliative care service at Children's that is really good with helping families figure out, like, we know we're not going to have very much time. How do we want to use the time that we have with our child?
Yeah, and those services are remarkable, and they are available a number of places, and hopefully they're the things you want to know exist but never want to have to access. So we will talk, like I said, in a couple of weeks to the newborn medicine folks, and it's very interesting to hear their perspective, and I've had the fortune of talking to many of them over the years about what they see and how they counsel families, and really I think more than anything, and we talked about this earlier, about how you remember the highs and you remember the lows. And I think the lows really stand out more, just
but
because
we usually are living right in the middle, and people forget about the middle.
And the middle is usually a-okay. I mean, it isn't perfect, but it's a lot of times great. And then the success stories that we see are pretty remarkable.
Well, and one of the things that we do with the team approach is we counsel together. So whenever possible, which is over 90% of the time, as the maternal fetal medicine physician and our neonatologist, the baby doctors, we will go in and talk to moms together so that we are all on the same page. Everybody's hearing the same information, and we kind of give the pregnancy perspective, and they help provide, this is what we can potentially do when the baby gets here. And I think that makes the picture, it's not perfect, right? You never know until you've lived in those shoes what it's going to be like, but we try to give patients as much information as possible from both teams together.
And it'll be so fantastic. I know we've talked a little about people in St. Louis having the frustration, and we drive through it every day on Kings Highway, about the amount of construction that's been ongoing for the last few years. And it's to a great end. And a significant part of what's being put together right now is this Women and Infant Center, which will enable
very excited about
everything you see. There's a balcony that connects to not balcony, a walkway, a bridge walkway that connects two of the buildings, and that connects mom and baby. And so very soon you'll be on the same floor with a lot of those newborn medicines and medicine specialists and maternal fetal medicine and OBGYNs, and it'll be a lot easier to have those conversations and make everything relatable, which we're looking forward to.
Yes.
And we're also looking forward to this beautiful new facility where mothers will be able to deliver babies. And before we let you go, and it's so funny because I started this and I was like, I can't imagine we'll go past 30 minutes. I have no idea how long we've been talking, but I know it's been more than 30 minutes. Do we have any questions?
We have two questions, and they're two very specific questions.
Okay.
So Laura says that she's on blood thinner injections because of an unknown cause PE 4 years ago. My baby's measuring in 70th percentile at 17 weeks. Do you recommend stopping blood thinners? I already can tell you the answer to the question. Should I go back and rewind the tape?
Yeah, so I would say stay if they were prescribed, someone felt that you needed them. And one other thing is, we talked about before we were on camera, second opinions. So I am never offended when a patient gets a second opinion, and no physician ever should be. So if there's ever something that's happening with the care where it's like, I'm not sure about this, I'm not comfortable, or even if it's like, I totally trust my doctor, but I just want to make sure that another person agrees with them, go for it. I think that we all need to take ownership of our care and advocate for ourselves. And so, in terms of probably on Lovenox most likely, it's either go back to the doctor and kind of say, can you explain to me exactly why I'm on this? Or go get a second opinion and make sure that it's indicated to be on it. So I'm not going to say come off of what the doctor prescribed, but we would be happy to see you in consultation.
And did you say there was one more question?
Is.
Okay.
Yep. So Mindy says that, or asks, would you recommend trying again after 3 highly complicated pregnancies and deliveries and 1 most recent stillbirth at 27 weeks due to undiagnosed NTHFR revealed in the autopsy?
Okay. So first of all, I'm really sorry. It's a heartbreaking decision, but I say that's a situation where it's good to come back kind of like once your heart is healing from like all of the emotional trauma and the grief of that loss, to figure out, what was the underlying thing that happened? What are the chances it will happen again or not happen again? And am I willing to take that risk? So I think that that's a really good kind of preconception consultation to go through. And the other thing I will say is sometimes just with the drama, it's like you feel like you're the only person who's ever been through something so horrific, right? Losing your child is something that nobody should ever have to go through. And we also have wonderful services and support groups to help moms who have been through similar situations. Because we're the regional referral center and people come here from everywhere, unfortunately we have our unfair share of moms who have been through similar situations. So I'd say, number one, you're not alone, that there are services and support services to help. And once you're ready, I'd say it's worthwhile to have another conversation with a high-risk physician to talk about what can we do to try to prevent these things.
Where could she or another woman in a similar situation go to get access to those support groups and the services?
So I will say that our MFM nurses, Molly Henson and Larissa Benhouse, are phenomenal, and I basically always ask them. They put
How about
our
I'll
patients
post it
in
in the
contact.
I was going to say, I
That sounds
think
good.
that, because
Yes.
I'm trying to rake the back of my brain. I know that I have the website in there along with the phone number, but I think that there have been a lot of services mentioned in this that we'll go back and need to include in the comments so that people have direct access to those. And also the place where they can call to get in touch with one of your colleagues as well. And that brings up another thing, and I feel like we're going to go for hours here because one question keeps spiraling into another. But the idea of, we talked a little bit about community hospitals and second opinions before. Once your pregnancy is determined to be high risk, do you need to be looking at the facility where you're going to deliver your baby? And what do you need to be taking into consideration?
So I think the general answer is yes. Usually the primary obstetrician is going to be pretty good at saying, you're totally fine to deliver here, we can handle this, or you really need to deliver someplace like Barnes or go to St. Louis. And in general, you think about 2 things. So one is mom, and what are mom's medical needs, and can mom's needs be met in the community? And like I said here, we practice with a team approach. So it's not just that I'm so great and so come to Barnes Jewish Hospital to deliver, right? It's because we have a dedicated cardiologist who is really interested in pregnancy and cardiac disease, and I have her on my cell phone on speed dial, right? Mm-hmm. It's that we have hematologists, and we have all of these specialists who help us to manage these patients. So nothing against community hospitals. I think that what we have to provide are this wealth of resources and this depth of physicians who really kind of are super specialized. So for mom, I'd say, where are your consultants? And do they have a cardiologist who feels comfortable with you if you had cardiomyopathy in your last pregnancy? And then for the baby, usually it's a hard and fast rule in terms of how many weeks a baby is and can that community hospital deal with it. So most places are not going to feel comfortable dealing with a baby born less than 34 weeks. Or if the baby has a congenital defect, that baby probably needs to be born someplace like this, for the most part, where there's a neonatal intensive care unit. So definitely a worthwhile conversation. We have some patients who are seeing us literally because they need to deliver at Barnes, right? Like there's nothing else to it, they just need to deliver here. So, yes.
Are there any other considerations that you need to take into account with the high-risk delivery? Does it automatically imply C-section?
No. Actually, the opposite. So our goal
Really?
almost always is to get mom a vaginal delivery. Yes.
Huh.
So
I would not have known.
There are some situations where we need to do a C-section, but typically we try to do them for obstetric indications just like any other woman, just because the recovery in general is going to be much better after a vaginal delivery. So my hope is for high-risk patients and all patients that you get a vaginal delivery. There are some exceptions to that rule, but it's the exception, not the rule.
Okay, fantastic. So are there, and then as far as the delivery itself is concerned, I know that there are some situations, whether you're talking about multiples or a very early delivery, where we've seen pictures or you have been in delivery rooms where there are a lot of people and a lot of folks who are dedicated to taking care of baby, taking care of mom, and taking care of that transition. Are those teams available anywhere, or will your OB direct you accordingly if you need to be in a place where there are a lot of folks focusing on your care?
The OB probably will direct it. Yes, it can. We have big birthday parties, not infrequently. But I will say, even with the big birthday parties, I feel like the time when you deliver a child is a sacred, really special time. And so even when it's not normal because it's high risk, we try to make sure that mom has a nice birth experience. And so for all of the people who were watching, if I was a mom who was pregnant about to have a baby, even if it was high risk, this is what I would put in my birth plan. Not the 10-page birth plan. It's a real simple birth plan, right? Which is when my baby is born, if the baby comes out and looks good, so it's vigorous, like breathing, not blue, I want the baby on my chest, right? Like I have been waiting 10 months to meet this little person. I want them right here. And give the caveat, if the baby is in distress, please take them, right? Take them to the pediatricians. But if the baby's okay, I want the baby right here. And if the baby's doing okay, I would love for my support person, husband, other parent, whatever, to cut the umbilical cord. Sometimes it's not possible, right? Like sometimes the baby comes out and the baby's in distress and we are just trying to take care of that child. But I'd say even when things are high risk, we still try to give moms that nice experience. And so I'd say advocate for yourself and let your nurse and physician know like those things are important to you if they are.
That is really good advice. Do we have any other questions?
No.
Do you have any other points that you think we need to cover here?
That's it.
All right, I love that you ended on the birth plan because toward the end of April we are going to be talking in detail about those, and I love that you brought up the 10 pages versus 1 page. I can't wait to see. We have an OB and a labor and delivery nurse who are going to be there to talk about that with us. So it'll be so fun to hear from them what they've seen over the years and what they recommend. And I know the templates out there do get a little bit long. I'm like, I don't know. I didn't even know that was an option. That's amazing.
Well, I think operating in good faith, like you choose your team and you have good faith that these people have my best interest at heart, right? They're not trying to harm me. They're trying to take care of me. And when they're pushing back a little bit, it's probably because they're worried about the safety of me or my child. I feel like it's sad that sometimes there's an antagonistic relationship. And I can speak for all of my colleagues when I say sometimes we disagree with what the patient plan is, but it's usually coming from a genuine point of we're concerned that something is not going to go right here. So I think it's nice when there's that trust and there's the relationship. And I think everything flows much better.
Everybody wants the same outcome.
Right. We all want a happy mom, a healthy mom, and a happy, healthy baby.
All right. Dr. Ebony Carter, thank you so much for making time to talk to us today for as long as you did.
My pleasure.
I can't wait to look at my clock and see how long this has been going. And again, it may take us a little bit, but we will in the next day or two, certainly by Monday, have links in the comments, if not before, to a number of the resources that we talked about today. So thank you so much for joining us. We will see you next week to talk about ultrasounds.
Thank you.